Pratik, are we live?
Yes, Rahul, we are live.
Pratik?
Yes, sir. Yes, Rahul, we are live.
Yeah. Can you put me on mute? Yeah, thank you, Pratik. So, very good evening, doctors. Welcome to the new season of Diabetes Essentials Season 2. And these online modules are an educational initiative from Menazal Zero and in memory of late Dr. K.K. Agarwal, sir. Dear viewers, today's topic is hypertension and diabetes. Now, why this module? The reason being the growing burden of hypertension and diabetes is one of the major public health challenges being faced by health system in India. And therefore, understanding how diabetes and hypertension prevalence varies within the country, which is as large as India, is essential for targeting of prevention, screening, and treatment services. So before I hand over the platform to Dr. Kalra sir to take us through today's module, which forms a very important milestone in our journey of 52 weeks, let me have the opportunity of announcing the names of those doctors who have answered the quiz questions correctly of last episode. And the names are Dr. Satish Kumar Jain from Karnataka. From Maharashtra, we have Dr. Dharmika Tandon, Dr. Kulbhushan Tandon. From Odisha, Dr. Gangadhar Rath. From Punjab, Dr. Sanjeev Puri. And from West Bengal, Dr. Santanu Kumar Bhattacharya. Dear viewers, as you all know that we have a very big tentpole event coming up on 14th August, which is on the occasion of World Pre-Diabetes Day. On 14th August, Dr. Julio Rosenstock, who is the director of Dallas Diabetes Research Center, USA, will address the Indian audience on newer drugs for diabetes, which forms a very crucial part in serving the patients of our country, looking into the diabetic population increasing in today's scenario. And this session will be moderated by our very own Dr. Sanjay Kalra sir. Dear viewers, if you have not registered for the event, please do register on the link provided, that is enerzal0.com. This session will be on 14th August, that is on Sunday from 9 p.m. to 10 p.m. I also hereby request you to spread this message to all of your colleagues who like to keep an interest in updating diabetes. The previous two events, which was with Dr. Vivian Fonseca and Dr. Om Ganda, are there to view and watch on the same platform. If any of the viewers wants to go to the same session, they can either scan the QR code on the platform scene, or they can watch on the same platform in the archive section. And with this, let me hand over the platform to Dr. Kalra sir. Sir, over to you.
Thank you, Rahul, and good evening, viewers. It's always a pleasure meeting you, being with you on Sunday evening. And like I said last time, I've begun looking forward to Sunday nights because I'm able to meet all my old friends and make new ones as well. Last week, we spoke about dyslipidemia and diabetes. Today, we'll speak about high blood pressure. We'll speak about hypertension. We've been talking about various aspects of diabetes care over the past few months. Let's do a revision about hypertension. This is something that we had discussed in Diabetes Essentials Season 1. Now, high blood pressure or hypertension is one of the leading risk factors for atherosclerosis. Diabetes is also a leading risk factor for atherosclerosis. There is a lot of overlap between their causation, between their clinical presentation, the clinical course, and also the choice of treatment. But do note that hypertension and diabetes coexist and there is an overlap, but there is an even more substantial overlap between dysglycemia and raised blood pressure. What does this mean? It means that we should be more proactive. Do not wait for dysglycemia to progress to diabetes. Do not wait for a relatively high blood pressure reading to worsen up until you label it as hypertension and begin treating. The moment you see dysglycemia or prediabetes, the moment you see a high blood pressure reading, focus on that, manage it. You can manage it non-pharmacologically, that is a separate matter. But at the same time, screen for the other condition. So in persons with pre-diabetes, we should check blood pressure. In persons with high BP, we must do a GTT. This is the take-home message. The pathophysiologic mechanisms are well known to us. Let us just go through them one by one. Genetics is important. There are many single nucleotide polymorphisms. If you do a genetic study, then you will get this SNP, single nucleotide polymorphism. These can help predict whether someone is going to get diabetes or high BP. But these are usually not done in our practice. And there are monogenic forms of diabetes. Monogenic means that a single gene is involved. Examples of monogenic diabetes would be neonatal diabetes. Neonatal diabetes is something that occurs within the first 1 year, not 1 month, between the first 1 year of life. And another example is MODY, MODY, maturity onset diabetes of young. Apart from genetics, environmental factors also play a role. So we are aware that our environment influences us not only physically but genetically as well. This is known as epigenetics. So if you are exposed to adverse environmental factors, your DNA can get changed. Methylation of the DNA can occur, for example. And this is important. This also can lead to metabolic disease like diabetes and hypertension. It is said that the seeds of hypertension are laid when the person is in utero, when the concerned individual was in utero, was part of his or her mother's womb. That is when these environmental and lifestyle factors begin to play a role. This means that we should focus on pregnancy as a means of optimizing health not only for the mother but for the child as well, for the unborn child. This brings us to the concept of transgenerational karma or transgenerational karam. What does this mean? It as simple as A, B, C, D, E. If you are able to fix 5 numbers in the pregnant woman, you can ensure good health for her and for her unborn fetus. A for anemia, B for blood pressure, C for circumference, that is abdominal circumference or abdominal girth or weight gain during pregnancy, D for diabetes, and E for endocrine. In endocrine, read TSH, hypothyroidism. We should manage that. So if you're able to fix up this A, B, C, D, E, you can actually prevent the fetus from developing cardiometabolic syndrome later on in adulthood. Another factor which influences both blood pressure and glucose metabolism is obesity. So some of the genes which cause susceptibility to diabetes also cause susceptibility to obesity and vice versa. And the pathophysiologic mechanisms are similar. Not only the genes, but the concept of insulin resistance is something that binds obesity, diabetes, and hypertension together. This does not mean that thin people cannot be hypertensive. Certainly, it does not mean that. But if you do have a thin person with severe hypertension, then think twice before labeling that patient as having essential hypertension. It is possible that the person may have secondary hypertension. Maybe it's an adrenal cause that we are missing, maybe a renal cause. So think adrenal, think renal in non-obese persons who have hypertension. Another situation where you should think about secondary hypertension would be extremes of life. That is, individuals who develop hypertension very early on in the course of their disease or in the course of their life, or very late, maybe at age 60, 70, 80. Suddenly there's severe hypertension. Why has it come suddenly? Think of a secondary cause. Think renal, think adrenal. Other etiologies of hypertension and diabetes include inflammation and oxidative stress. A disease like chronic periodontitis, that is inflammation of the gingiva, gingivitis, periodontitis, that has also been shown to predispose to development of both hypertension and diabetes. All said and done, it is insulin resistance which is pivotal in developing diabetes and hypertension in our country. So if you have a patient with diabetes and hypertension, then the message we get is that we have to focus on insulin resistance. We have to reduce that. We have to promote insulin sensitivity by both non-pharmacological methods and pharmacological means. Another aspect of blood pressure pathophysiology that we all are very painfully aware of is mental stress and the sympathetic nervous system. Chronic mental stress is associated with various physiologic and psychological disturbances, and these can indirectly precipitate both diabetes and hypertension. Stimulation of the sympathetic nervous system is an adaptive mechanism. Let us say you have an examination. The sympathetic nervous system will go into overdrive. You will study harder, you will study longer, and you will pass finally. So it is adaptive. Suppose a lion decides to eat you up, gobble you up, and run after you. Then you will run fast. That is an adaptive mechanism. But supposing there is continuous sympathetic tonicity, the sympathetic nervous system is stimulated continuously without any rest, it will burn out. This we learned from the dopaminergic system. So when you say sympathetic, you think of adrenaline and noradrenaline. But if you go to the brain, you will see that the major catecholamine is dopamine. So we call Delhi, for example, or Dubai a dopaminergic city because the city never sleeps. In migratory birds, what they found out was that when the bird has to fly for a long period of time, the dopaminergic tone increases. But when the bird rests, when the bird doesn't fly anymore, the bird doesn't need to fly, then the dopaminergic activity comes down. So dopamine is an adaptive molecule. In the modern world, however, we have continuous sympathetic stimulation, continuous dopaminergic stimulation. This also leads to stimulation of the renin-angiotensin system, the renin-angiotensin axis. This causes high blood pressure. And when it is done in a continuous manner, this becomes maladaptive. And this is one of the reasons why the epidemics of diabetes and hypertension are worsening so rapidly. Now that we have learned all about this, what is the take-home message for us as physicians, as general practitioners? What should we be doing in our OPD? First thing is to measure BP, and please measure it accurately. Do remember to measure blood pressure not only in people with diabetes, but also those with pre-diabetes, in those who are obese. You can check blood pressure in the OPD, that is clinic-based. You can also check it at home. Ambulatory blood pressure monitoring can be done. If you have a busy clinic, there is no harm in investing in an ambulatory blood pressure machine. You will give it to your patient for 24 hours. The patient will take it home. You will apply the BP cuff on the non-dominant arm, and the measurement will be done every 15 to 30 minutes over 24 hours. You will have to change the battery each time. So it is a good thing to use in your practice if you're practicing internal medicine or cardiology. But do note that the cost of the batteries can be quite significant actually. When you do ambulatory blood pressure monitoring, you will be able to find out whether there is a circadian rhythm or not. In a normal person, there will be dipping. Dipping means that blood pressure will fall by more than 10% during the night. This is normal. If you have a non-dipper means that BP is not falling during the night. This is a risk. This is a sign for adverse cardiovascular outcomes. You may also want to check what else is going on at night. So you may wish to do a sleep study. Different types of sleep studies are available. There is something known as a class 4 sleep study, which is a screening study. You can do that in practice. It costs about 4,500 rupees. All you have to do is apply a small sensor over the finger, over the tip of the finger of the patient. And you need a Bluetooth enabled telephone right next to the patient within 2 feet. And you do it for 3 nights. And that will tell you how much of apnea, how much of hypoapnea is going on at night. You may also wish to measure glucose levels. Glucose levels can be associated with dipping or non-dipping of blood pressure. So if you have access to ambulatory glucose monitoring or CGM, that is fine. Otherwise, if you feel that you are not able to, get a grip of what the patient is going through, all you do is a glucose level before dinner, 2 hours after dinner, at 3 a.m., and then when the patient wakes up fasting. That 3 a.m. glucose will tell you whether glucose is falling or not during the night. So our first take home is we must measure blood pressure, and whenever required, we must measure glucose as well. And there's no harm in screening for sleep apnea as well in patients whom you feel are at risk of obstructive sleep apnea. What else should we do? The recommendations tell us that if the blood pressure is more than 140 by 90 millimeters of mercury, check blood pressure again and again. Do multiple readings. Check in both arms. If the patient is complaining of giddiness, vertigo, if you find other features of autonomic neuropathy, then do rule out orthostatic hypotension. Check the blood pressure while the patient is standing, sitting, and lying down. If the BP, however, is more than 180 by 110, then you can diagnose hypertension with a single reading. If the patient has high BP with coexisting cardiovascular disease, then also you can diagnose hypertension with a single reading. And if your patient comes and tells you that, Doc, my BP is 130 by 90 now, that's fine, but I have been taking blood pressure lowering therapy for such a long time, then also you can diagnose hypertension because the patient is giving you a history of taking antihypertensive medication. Many times patients will come and say that, Doc, at home my BP is fine, but the moment I enter the hospital, I begin to feel afraid and my BP goes up. This is known as white coat hypertension. And I tell my patients, yes, exactly the same thing happens to me when I go to the dentist. And also when I go to the bank. When I go to the bank, I am always afraid. I am petrified that I will end up signing on the wrong page somewhere. So if you feel that white coat hypertension is a possibility, then encourage your patients to check their BP at home. They should check at different times of the day and also at night. This was about screening. What are the thresholds and what are the targets for treatment? Ideally, the targets for treatment and the thresholds for starting treatment should be individualized. You should speak with your patient, listen to him or her. If the CV risk is high, then you would want a tighter target of 130 by 80. If the CV risk is low, then a target of 140 by 90 will also suffice. At the same time, do remember to ask about symptoms. So this is something that I've seen in Western guidelines. There is a total lack of mention of symptoms of blood pressure. But as Indian physicians, we all know that our patients come in only with symptoms. That is why they are visiting us in the first place. So if your patient has a BP of 140 by 90 or 136 by 86, and the patient has symptoms, it can be a headache, it can be ghabrahat, uneasiness, it can be vertigo, it can even be a symptom as innocuous as, there is gas in my head. I think my head is bursting because of gas. Do give your patient the basic respect that you would demand yourself, that you would expect yourself. And if you feel that that symptom can be tied to hypertension, do not hesitate in treating it. I'll tell you my story. I used to go to my friend who is a cardiologist and tell him that I think I have high blood pressure because uh, I'm not comfortable. I get angry very fast in the OPD. I think my BP is high. And he would check my BP and say, no, sir, it's 130 by 90. No need for medication. But actually, when I took the medication, it actually helped me a lot. What will you do? Before medication, first we should try lifestyle intervention. And let me again speak from personal experience as a patient. Weight loss, even trying to lose weight, helps you improve blood pressure. When I try to lose weight, when I go to the gym, when I reduce my sodium to virtually minimal amounts, my BP improves. Taking a healthy diet with lots of colorful nuts, vegetables, fruits, that actually helps. Reduce salt, increase physical activity, especially aerobic activity, and avoid alcohol, and stop tobacco totally. But sometimes lifestyle modification alone will not help and you will need therapy. So 140 by 90 would be a threshold for virtually everybody. Begin monotherapy. 160 by 100, begin dual therapy. Patients with diabetes and hypertension will require dual therapy most of the time, in two-thirds of patients. So if let us say the BP is 150 by 90, 150 by 94, you are justified in starting a combination therapy. Right from the very beginning, you will be correct at least two-thirds of the times. In diabetes, the first line therapy should always be ACE inhibitor or ARB. But you will all agree that ACE inhibitor, ARB are not very potent blood pressure lowering drugs. So you need to add something. That something can be either a diuretic or a calcium channel blocker, either of these. There will be times when 3 drugs will be required. In a diabetes clinic, maybe in around 20% of patients. In such patients, the 3 drugs will be usually an ACE inhibitor or ARB, a diuretic, and a calcium channel blocker. So this is how we begin therapy. First choice, A for ACE inhibitor or ARB. Second choice, either calcium channel blocker or diuretic. And third choice, the other one, either diuretic or calcium channel blocker. You should monitor for renal function regularly. And in patients who are at risk of renal disease, you should monitor serum potassium also regularly. There will be some patients who will not respond to 3 drugs as well. So if you have a patient who has resistant hypertension, then the 4th drug that you will add will be a mineralocorticoid receptor agonist. Examples can be spironolactone, eplerenone. Eplerenone is a very good drug to use. You can start 25 milligram OD and sometimes 25 BD or 50 OD. Another drug that will soon be available in the Indian market, that is next month, is finerenone, which is another mineralocorticoid receptor antagonist. This is approved and is indicated for use in patients with diabetic kidney disease, and it is approved for prevention of progression of kidney disease. So these are some of the things that we spoke about, that we had to discuss today in hypertension. Let's take our quiz for today. Which of the following are recommended goals for the prevention of cardiovascular disease in adults with diabetes? And the goals we are talking about are related to blood pressure and lipids. So is our goal a blood pressure of 140/90, triglyceride less than 150 milligram percent, LDL less than 100 milligram percent, or BP less than 130/85, triglycerides less than 30, LDL less than 100? Or is it a BP less than 135/80, triglycerides of less than 200, and LDL less than 130? Or is it the last one, BP less than 130/80, triglycerides less than 150, and LDL less than 100? Let me repeat again. We are talking about targets. We are talking about blood pressure goals and lipid goals. We are not talking about thresholds when you begin pharmacological therapy. So with this, let's move on and let's take the questions from the audience. And lots of questions as usual. So warm welcome to Dr. D.G. Parmar. Dr. Parmar shares that some diabetes patients with comorbid osteoarthritis of the knee and degenerative spine cannot walk regularly. What is the equivalent substitute for walking? Thank you, sir, for raising this. In developed countries, they do swimming or they do underwater exercise, because when you go into the swimming pool, then there is less pressure on the knees. So they do their aerobics in the swimming pool. That may not be feasible for most of our patients. So they can do sitting yoga, lying down yoga. You can ask them to do that. And they can do the exercise of quadriceps while lying in bed. Do teach them that we cannot do much about your knee joint. But what we can do is we can improve the quality of your muscles above the knee and below the knee. So if you do those exercises, the muscles will take more load and your knee will be able to relax. This is for strengthening the lower limbs. For burning calories, upper limb exercises like weightlifting can also be done. These can be done while sitting. Dr. Vinay Desai has a query. If patient on thyroxine gets a large dose and becomes hyperthyroid, yes, TSH becomes low, can this increase the HbA1c? So not directly, but HbA1c is linked with the lifespan of the RBCs. Patients who are hypothyroid can have insulin resistance, but usually they have insulin sensitivity. So hypothyroid patients become hypoglycemic very fast. When you make them hyperthyroid, there is increased sympathetic tone, increased counter-regulatory hormone release, and they become hyperglycemic. That is why you are saying that the HbA1c rises. That is true. and it can unmask diabetes. This is also true. To such patients, what we can do is we can reduce the dose of thyroxine and counsel them to wait for a few weeks. So that the patient doesn't get afraid, we can say you may be having stress hyperglycemia. Let us just keep you on diet and exercise. And you can give a DPP-4 inhibitor that is safe. Do not give large doses of metformin. You can give a DPP-4 inhibitor, small doses of sulfonylurea, and you can review the patient after a few weeks. Dr. Desai also shares another clinical challenge. 54-year-old lady on premixed insulin 30/70, 15 units before breakfast and dinner. That is average dose. Before breakfast, glucose is 90, which is very good. So that means our nighttime dose of 15 units is perfect. Before lunch, it is 200. Now it has gone up. And before dinner, it is 210. It has gone up even more. So what we will do is we will tell the patient to continue the same dose at night, 15 units. If you are worried about hypo, then you can also reduce it to 12 or 13. But I think personally 15 should be fine. The daytime glucose levels are high, 200 and 210 before meals. So the breakfast dose can be increased to 20 units also. We can give 20 plus 15. Now, since we are not covering lunch, that is why the pre-dinner glucose is 210. So what we can do is, if patient is not willing for a third injection of insulin, usually they are not willing, we can add acarbose 50 milligram or acarbose 50 milligram plus metformin 500 milligram combination. If you want to add a very economical drug, then the choice will be glipizide 5 milligram plus metformin 500 milligram, fixed dose combination. Glipizide, the commonest trade name is Glynas. So, and what Dr. Vinay says is right. The night dose will control the fasting, so that is taken care of. And the morning dose will control post-lunch, pre-dinner. And since we are not doing a good job, we should increase the pre-breakfast dose from 15 to 18 or 18 to 20. Dr. SN Ali says joint pains, this is very common. So basic hygiene for joint pain management would be lifestyle. Begin exercising your joints, but not too much also. Calcium, vitamin D. And our traditional Haryanvi treatment is haldi wala doodh, which actually does wonders. So haldi wala milk or turmeric milk. Diabetic nephropathy starting symptoms. The drug of choice would be ACE inhibitor or ARB. Tight glucose control. Tight blood pressure control. Avoid urinary tract infection. Treat urinary tract obstruction. And stop smoking. So let me repeat these 4 things for nephropathy. Tight glucose control, tight blood pressure control, including with ACE inhibitor or ARB. Prevent or correct urinary tract infection, urinary tract obstruction. And the 4th is stop smoking. So thank you, Dr. Ali, for raising these common points. Dr. Anand says diastolic blood pressure is around 90 millimeter for a patient, systolic 120 to 130. That is fine. Weight is 94 kg, age 47, chronic asthmatic, non-diabetic. So this is essential hypertension. It is part of aging and part of obesity. We will tell the patient it is essential hypertension. Probably we don't need to give you a medicine, but if you can try to reduce weight, your BP will come down. Reduce salt, reduce sodium. How do you tell the patient to reduce sodium? The 3 P's, papad, pakoda, pickle from Indian diet. The 4th P from Western diet, P for pizza. Papad, pakoda, pickle, pizza. From the K series, some vegetables are there which take a lot of salt. Karela, kathal, kadi. And the 4th K is ketchup. So these things to be avoided. Dr. Asha Kumar Rastogi reminds us that beta blockers were used earlier as antihypertensive. Now they are not included in the list anymore. Beta blockers can be used only in heart failure and as anti-anginals. If you have a patient who has tachycardia, then you can give beta blocker to reduce the pulse rate. In anemia and CKD, Dr. Suresh Pawar says, so usually HbA1c is false low. Usually it is relatively low in CKD and anemia as compared to the fasting and postprandial glucose. Dr. Gangadhar Rath asks about prescribing antihypertensive drugs in the morning and bedtime. This is an upcoming field now, chronobiology. And many studies suggest that when you give these antihypertensives at night, the results are much better. If you're giving a diuretic, it should be in the morning. If you're giving an ACE inhibitor or ARB or a calcium channel blocker, any time is okay, but there's no harm in giving at night. There are many studies which say that you should give at night. If by chance you are giving a beta blocker, patient has already been on the beta blocker, you don't want to stop it, or you are giving as anti-anginal or for heart failure, then it is better given in the morning. So diuretics and beta blockers in the morning, all the others either in the morning or at night, anytime. Many other questions are there, and we welcome everybody. Dr. Gauri Shankar Dharmaraj is there. So the question is, how do I answer the quiz questions? Pratik is there backstage, or Rahul will be joining us in a minute now, Rahul or Mr. Anand, and they will explain how to answer. I apologize, I am not aware of this technicality. If BP is 130 by 80 and patient has type 2 diabetes for 5 years, is it necessary to start antihypertensive? No, no need. You do monitor every few months and counsel the patient to reduce salt, do regular physical activity, stop smoking. That should be enough. HB 9.5, we must give iron. Certainly we must. And Dr. Dharmaraj, thank you for raising this. In September, we will be starting a series of talks every Sunday called Iron Talks. And why we have chosen this topic, Iron Talks, is because it is actually very important. We sometimes forget to supplement iron to our patients with anemia, and then the outcomes are suboptimal. Overall health outcomes, happiness outcomes. Again, Mr. Basu or Rahul will talk to us about when the iron talks is going to start. I think it is first week of September. Another question is, diabetic patient with left ventricular hypertrophy, any medication we should start? Yes, like you have rightly said, we must start antihypertensives. Choice will be ACE inhibitor, ARB, and diuretic. It is a target organ damage. We must give statins, that is to prevent. So if the patient is aged 40 and above, statin must be started. If the patient is aged below 40, then statin will be started if lipid levels are high. And oral antibiotic for cellulitis or wound in the leg, choices would be either co-amoxiclav, 625 milligram twice a day. Sometimes you give thrice a day as well. Another good drug you can use is linezolid, but it is expensive. So my first choice would be co-amoxiclav. One trade name is Flemiclav, 625 twice a day, rarely thrice a day. Don't forget to add metronidazole. So metronidazole or satronidazole coverage must be added in all patients with diabetes. And usually it is about 7 to 10 days. In routine OPD, if you are giving for 5 days, in persons with diabetes, just as a rule of thumb, as a heuristic, just add another 2 to 3 days. IV, again, co-amoxiclav can be given. If you want cheap and best, then that would be maybe a combination of ofloxacin, metronidazole, and gentamicin or amikacin. That would be the cheapest and the best. A warm welcome to Mr. Sharma from Lucknow and also Dr. Yogesh Uplenchwar. So it's very good having all of you with us. Thank you for all your questions and comments. Hypertension is something that can actually be life-threatening. And like Dr. Shashi Khare says, 30-year-old patient taking telmisartan and chlorthalidone and amlodipine, sometimes BP shoots up. So what we can do is, if you're giving a triple dose drug therapy, you can change that. You can give telmisartan, chlorthalidone in the morning and amlodipine at night. Or you can make amlodipine twice a day, 5 milligram twice a day, or maybe 10 milligram at night. If the BP is shot up, ask the patient to keep a diary. What did the patient eat in the preceding few hours? Did the patient have any stress? And that might give you clues. In stroke, should you treat hypertension immediately or wait and follow up? Dr. Gangadhar Rath has this query. If it is hemorrhagic stroke, that is usually because of high blood pressure, and you should bring the BP down. If it is ischemic stroke, then you just keep the BP around 140 by 90. Don't try to bring it down very low to 110 by 70. In hemorrhagic, you should bring the BP down fast. In ischemic, you can just relax your target slightly. SGLT does control blood pressure and diabetes both. I think antihypertensive drugs still should be given, Dr. Gangadhar Rath, but the dose will be much less. Again, what I have seen in my patients, let us say I was struggling with a patient with telmisartan 80 and chlorthalidone. When I added SGLT2 inhibitor, the BP came down, and it was such good control that I could take off the chlorthalidone. I just kept the patient on telmisartan and SGLT2 inhibitor. Thank you, Dr. Suresh Pawar, and thank you, Dr. Syed Muhammad Abbas, for your kind words. It is great being with you and great having all of us together. So, with this, I'd like to thank everybody for having shared your time on this Sunday, and I'd like to hand over back to Team FTC.
Yes. Thank you, sir. I think to answer the first question of our Dr. Viewer is that on your screen on the right side there is a place where you can type the answer A, B, or C or D, and just submit it. We get the answers against your name. That's the first thing. And as Dr. Kalra said that we are starting diabetes essential. Within the diabetes essential, we have going to have a 1 month series of, I think, 2 month series of 2 month series of iron talks, where all the guest speakers are going to be there with different subjects. I think that we will start promoting from next week. And the third thing which Rahul must have already taken is the 14th August on World Pre-Diabetes Days. We are going to have international speaker Dr. Julio Rosentek. So this all will start promoting from next week onwards. So get tuned to the days and dates on our regular Sunday evening show only, so that every Sunday we will tell you what is going to be there on the next week agenda. So with this, I thank Dr. Sanjay Kalra for taking a wonderful session on hypertension and diabetes today. Thank you, sir. Jai Hind.
Jai Hind.
राज बाहर है आप